All right, Rebecca. This is I guess episode 19 now. Welcome.
19, and that's in 2 months, right?
Yeah, it is. I've been moving a little fast. I'm gonna start uploading weekly instead of at first I was kind of just pushing episodes out. But yeah, it's been fun. I mean, we're in the same master's program, so I like to talk. But yeah, it's been cool to do and excited to have some good conversation. So welcome. So happy to have you
Thank
here.
you.
It's 1:30 p.m. and where are you exactly? I know you said you're at your sister's.
I'm Yeah, I'm in the sisters. I'm in Meerstad, which is near Groningen, which is in the north of the Netherlands. So I work in Amsterdam. I live in Amsterdam, but I have 2 weeks off. So I'm spending it at my sister's place.
I'm
Yeah,
sure. I'm sure that's very nice to have 2 weeks off.
absolutely. It's been really good to wind down and not have to worry about work for 2 weeks. That's been really good.
Still got to worry a
Yeah.
little bit about school, but at least at least work gets a little rest.
Yeah, but it's also fun. I know how you feel about our program as well, but it's been mostly fun. It's been a lot of work, but it's been mostly fun, and I think the topics of core three are going to be really exciting as well.
Yeah, yeah, and super important stuff. Well, before we talk about school, let's go way back. Let's talk about your background. You've done a lot of really cool stuff in healthcare. I believe you told me at one point that you actually didn't think you were going to go into healthcare starting out. So I'm just curious what have your experiences been? How do we end up where we are today?
Okay, so I'm an anesthesiologist. I'm also an intensivist by training, but just doing anesthesiology right now. Um, so how did I end up there? After high school, we have a lottery system to get into medicine. So I didn't know wanted to get into medicine. Didn't manage to get in at first. So did some computer science before.
That's right. That's what I
Um,
remember you. You told me something about computer science.
right.
Just
Thinking about what we called back then technical cognition sciences, which was later renamed to artificial intelligence, but we've hardly knew about that topic back then.
yeah, small topic now.
Um, yeah, right. I didn't even expect it to be this big, but now finally, 2 years later, I got into medicine, and so I did that for 6 years. Um, got into medical research. That took me to New York City for a while, 3 years. Then went back to the Netherlands, worked all kinds of medical jobs as a resident, what we call resident not in training, just to find out what kind of job suits you and get some work experience. So did quite some work in intensive care medicine, neurology, and ended up in anesthesiology in Amsterdam. I liked the program there because it was very focused on patient safety, which was already an interest of me by then. Did my training there also in intensive care medicine, and yeah, that took me to where I am now. I'm still working in Amsterdam at the Amsterdam University Medical Center. And I'm an anesthesiologist. I also work on incident analysis in our department. I am one of the peer supporters in our department. We have a very strong peer support program, which is really, really important in my job. And I hope to hear some about that from your perspective as well.
Yeah. I
So, but
if we
that's
had a peer
that's
support program, well, we do to some extent, but if you were in my field, I would want you on that team 100%.
yeah. So I mean, that's basically the things that I do right now at my job. I also we have two locations in Amsterdam, and our anesthesiologists also work on the Dutch Caribbean island of Bonaire, which is one of the Caribbean islands near Venezuela. And
It always gets
so
interesting with the different territories. Like
Oh,
I feel like a lot of those countries in the Caribbean are just owned by, France or the Netherlands. It's but they're so
true,
far
true.
away.
They're very far away, and but it's well, it's our colonial history. I don't know if we should be proud of it. It has it's a very black side of history as well, I think. Um, but it's Bonaire is one of our municipalities, so it's a part of the Netherlands. Um, so yeah, we have a small hospital there that we go to as anesthesiologists, and we also work there on the air ambulance team to fly out patients from one island to the other, or for even more healthcare to Colombia. Um, yeah, so I have a strong focus on patient safety and also on taking care of colleagues. And this is also what brought me into the program at Lund, where we met on human factors and system safety. Just to learn more about how safety actually works in complex systems, because it's not that easy,
No.
as you know.
It only gets more complicated or more complex the more we learn
Complex,
about
right?
it too. Yeah. Can't conflate those words. But yeah, no, you've done a ton of stuff. It's awesome. I'm curious, what was your experience like in New York City? Because I mean, that's the biggest city in the United States is a huge country, and there's no city bigger in it than New York by far.
Yeah, yeah, it's a good question. So I grew up in a small village in the east of the Netherlands. So that was 2,000 inhabitants, and
2000.
2,000.
What's New
And
York?
when
12 million? Something like that?
yeah, yeah, I think it's 8 million on Manhattan alone. So
Oh.
yeah, but that may be including tourists. I don't know. Um, so I went to study to a university in Groningen, which is a very small city. I don't know how many inhabitants, but it's not a big city, and it's a large part of it are students at the university. And I thought I would never need to go to any place bigger than that. So after that, I moved to New York, and coming back to the Netherlands, I knew I could never go back to such a small place again. I don't think that's necessarily true anymore, but yeah. So I moved to the west of the Netherlands, where the big cities are. Amsterdam is obviously one of our big cities. But my experience in New York, I thought it was great. I loved it. I loved. I felt very at home there. Um, I loved how every part of the city was totally different, and I didn't feel lost in such a big city at all, because in the end, you have your supermarket near your home where you know the people. You have your coffee place where you know your people. It's you create your own village within a big city.
Yeah, which is a
So
cool
yeah, I
experience in
loved
of
it.
itself.
Yeah. I live very close to Central Park, so yeah, that was my go-to place to escape the busyness of the city, and just to um, well, maybe artificial nature, but just to get out and feel you're wandering around in nature. And you could also just take the train out of the city, go
Yep.
upstate, and just to go for a hike. It's not that difficult either. So yeah, I've had a really really good time. It's one of the best times of my life.
It is funny. It's such a contrast. Central Park is like this giant park just surrounded by massive buildings. It's such a interesting juxtaposition. Is that the word? Yeah.
Right, and you can walk around there for hours. It just feels like an oasis in the city.
Yeah, yeah. Well, so my fiance and I were getting married in April, and we'd like to live somewhere outside of Nashville for a little bit. And New York City is actually something we've been considering, but it
Oh,
scares me
good
a
for
little
you.
bit because it's just such a big change. But I think, like you, I like staying busy and I like having a lot to do. And I mean, New York most certainly provides that.
Of course, yes. Well, first of all, congratulations.
Thank you.
Um, And yeah, I mean, New York will definitely provide that, and it's just it's been a really good experience. You don't have to live there for the rest of your life, but just to get that experience is amazing.
Yeah. So
It's different. It's different. It's
professionally,
different. It's different than going there for 5 days on a holiday.
yeah, definitely, definitely. I might be romanticizing the idea of it a bit, but it
Oh
would.
no, just go with it, and then romanticize away over there. It's fine.
Yeah, and it's not that expensive either, right? So that's
Let's not talk about that.
yeah, might as well do it while I'm young and getting experience. But professionally, what were you doing in New York again?
So I was doing medical research at Mount Sinai Medical Center. I was doing a project on liver cancer at the time, um, which was really really good. It was a really nice lab, and we had so many colleagues from the US, but also from outside of the US, and we worked really hard until often until way after midnight. But we still also took time out to enjoy the city, to explore everything it has to offer, and then go back to work. Because office hours didn't exist and didn't matter there, so you could just go out, see a
Show up
basketball
whenever.
game, and go back and work until 4 o'clock in the morning. That would be totally fine. Just get the work done.
Oh
Uh,
no, that I don't know. I like having some separation. I feel like you're blurring the lines there, but
oh yeah,
I'm sure it
but
was an experience.
we were young, right?
Yeah, yeah, yeah. I mean, I guess I say that, but then I'm on call for work. Sometimes I'll get called out at 3 in the morning, have to go to a house, to a gym,
Right?
whatever. So yeah,
Yeah.
it happens.
And for me, it's the same. We have plenty of night shifts. Our rhythm is disturbed anyway, so yeah.
Yeah, healthcare is just on a whole nother level in that sense. Like it's just expected and normal in a lot of healthcare places to be tired and sleep deprived and work weird hours. I mean, it's really bizarre for some of the most important work that people do that that's just been a thing, right? Traditionally, especially in training and stuff where, you keep people up for days and they're doing all the it's really insane.
Yeah, I think it's worse in the US because we do have much better caps on working hours than in the US. I think the US put a cap on like 80 hours. That to me is insane. To
It's
say, wait,
unbelievable.
that should be the maximum. Like, what was it before then?
It should be like there's an
And
emergency, we need people, not hey, just go work 80 hours.
yeah, yeah, it is not healthy, and uh, we have much better working hours. Still, you get sleep deprived, and your rhythm is all messed up. And that can be a problem, but I think the problem in the US is much worse, and that's worrying.
Well, this is so I was wanting to talk about this, and you kind of alluded to the differences between healthcare there in the US, and you may know more than I do. But what are your perceptions around US healthcare compared to places in Europe and or just in
Um,
general? I mean, I guess it.
yeah, so I don't know too much about the recent developments. So because with Obamacare or no Obamacare or whatever the political thing is right now, and
It's hard to
so
keep track
I
of,
don't know. It's hard, yeah, especially from the outside, but
even on the inside.
I think in the Netherlands, most of our care is paid out of health insurance, and we our general health insurance covers basically everything that you really need, and we have some extra options
Does that
for
health
extra physical therapy.
insurance, does it come from the government?
It no, it's private health insurance. But the basic package is determined by the government for every
Gotcha.
for every health insurance company. So the basic package is the same, and they can change a little bit in pricing, but there's not much wiggle room there. And then there are extra packages that you can add on that that they can differentiate. I don't have extra packages. I just have the basic package because it's really all I think I need. Um, and it's not tied to your job. So that's what I think is a really good thing, because if you lose your job in the US and you lose your health insurance, that obviously is a big problem.
Hmm.
Um, it's not if you want to change providers for the basic package, they cannot ask you any health questions. So not if you have prior health issues, that's not going to be a problem, because the basic package is just a solidarity package, so it's the same for everyone. Pricing is the same for everyone. Um, so I think that those things are really important, and it's mandatory to have health insurance. Some people, of course, don't have health insurance. We will still help them anyways in the hospital, and
Of
we
course, yeah, same in the US. You can't just say,
uh,
yeah, no.
no, but to a certain degree in the US. So
Oh, true, true. I guess I was thinking more, more emergency situations. They're of course
right,
going to help. But yeah,
yeah,
more optional care and other stuff. They would well, they would still do it, I think, but you would just go into debt. They would just keep sending you bills that you wouldn't be able to
right,
pay.
yeah.
And that could just
So
ruin your credit score. The way we have insurance and payments is so unbelievably frustrating in the United States. Like the amount they charge for things, what insurance covers, what it doesn't is incredibly confusing. And then oftentimes they'll give you a number that's not even accurate. You'll get the actual bill and it's much different than you were told. I mean,
yeah,
it's just wild the way we do it. And I broke had a spiral fracture on my left fibula about a year ago. It was just insane the charges for everything, for the x-rays, for the care, for physical therapy. They told me it'd be $20 out of pocket a session. And then I did 3 sessions, got my first bill back. It was $167 for each session.
mhm,
And they just
yeah,
said, sorry, our system was outdated. We ran your insurance wrong. And I still had to
yeah.
pay. It's, I
Yeah, so
mean,
that's crazy to me, and I think the co-payments are a big issue in the US. So you might have insurance and you still have to get into debt to pay the co-payments for everything. You have to worry constantly about, okay, my surgeon may be covered by my health insurance, but the anesthesiologist is going to be out of network. Um, how are you going to keep track of all of those
yeah,
things, and
the
how are you going to
in-network,
arrange your care?
out-of-network, it gets so confusing. And I work,
Yeah.
I work in child welfare, and a lot of times with families, we recommend services, or we're like, say a kid needs counseling or other stuff. Even something as simple as counseling gets really confusing for families sometimes on finding a provider that will accept their insurance, that it isn't a ridiculous amount out of pocket. I mean, it's a really bizarre system, and I don't know enough about it, like the history and everything that led to the way it is, but it seems so different from the way Europe does it, or a lot of
Yeah.
countries in Europe do it.
I think people here don't have to worry too much. If you go to a hospital, you need care, you will just get care, and the bill will mostly go to your insurance company. They will take care of it, and you should be fine. Um, and we also have really good primary care. So that's I think that makes the healthcare cheaper here, because most of the issues will be taken care of by your primary care physician, and you're not except for like real emergencies, you're not allowed to see a medical specialist before you go to your primary physician. So he
Mm,
will filter out a lot of the issues that he can handle.
makes sense.
Yeah.
You want to save
So
the the emergencies for emergencies, of
right,
course.
right. So I think that's also a way to keep our health costs down. Yeah.
Yep. Well, yeah. Oh, I'm envious, but
Well, it's one reason why I didn't want to stay in the US to work as a medical doctor. So I don't want to worry about, can I treat this patient? Is he insured? I just, I want to take care of patients, whether they have money or whether they don't have money, whether they have insurance or not. Uh, let people take care of that. But I just want to take care of the patient, and that's a lot easier in the Netherlands.
Yep. I wish, this podcast obviously is pretty small. One day maybe I'll have a producer who can do fact
Mm.
checking, but I would love to see. I remember seeing something crazy about the cost of giving birth in the US and how it's risen and what they charge now. I mean, it's thousands and thousands, if not. I saw this post the other day. This mom had a baby that went to the NICU, and her bill was $1.5 million dollars. She posted it on social media. It was like, this is how insane US healthcare is. But
Yeah, the
we can
Netherlands, zero.
to have a child.
To have a child, to
Oh,
to have your
wow.
child in the queue. I mean, it's not an issue at all. It's just part of healthcare.
Yeah. I mean, I'm sure
Just
that 1.5 million was before insurance, but still, it's unbelievable. But switching topics, something I know is near and dear to your heart. Let's talk a bit about mental health for workers in a field,
Mhm.
like healthcare, and I can relate on some levels in child welfare. But what's so it's interesting for me, and I'm curious if you have a similar experience, is sometimes it's not even always the case as you would think, but sometimes I just feel so bad for some of these families I work with, and it's just hard to shake that feeling, and you get invested in cases, and sometimes it's not the cases I think, but it's really hard for me to separate work and my personal life sometimes. Sometimes I'm good about it, usually going on a long walk helps, but it's really difficult, and I just see a lot of stuff where people are emotionally charged, and I know it's the same in healthcare, so I'll just, I'm not even going to ask a question. I'll just let you respond.
yeah, I've been thinking about it before this podcast as well, because it's a two-way street, and I think you have the harder job than me.
Oh, I think yours is harder. That's so funny.
um, so for me, in anesthesia, I don't see patients for a very long time uh, before they're asleep usually.
Makes sense.
I see people in a very vulnerable state. They usually get to meet me 5 minutes before they put their lives in my hands. And I
Yeah.
think that's something to be very aware of, because giving over control it's hard for a lot of people. Um, some of them are healthy, just getting surgery on to improve their lives. Some are really, really sick and don't know if they're going to wake up. I cannot even imagine how that's going to be, when I say, okay, the sleep medication is coming, sleep well, and how scary that's going to be. Um, but it's quite short that I have with the time that I have with patients. In the intensive care unit, it was a little bit longer, but sometimes it was also just when they come in and they're really sick, and you give them sleep medication, you intubate them, and then they're going to be asleep for a while. So it's mostly then the families that you have to take care of emotionally as well. And you never know when it's going to hit you. When something's going to hit home.
Yeah, I
It
think that's what I
might
was
be
saying.
it might be so many things. So sometimes it's someone in your age group. Sometimes it's a young child. Sometimes it's a mom or dad with young children. Those are cases that sometimes hit healthcare givers more easily. But I've also had it, talking to the family of an I think an 85-year-old, um, and then talking to the partner, and he was so strong. But when I left the room, he started crying, and it's like, I've been together with my wife for 60 years. and it just broke my heart. I was like, oh yeah, how is this not worse or better than a 22-year-old? It was he was his life. He was his love. I mean, that's
Oh, it's terrible.
um it is, and it's also beautiful, and it's also terrible. Um I think it's both. It's part of life, but it's also part of the beauty and sometimes
Yeah.
the horror of life. But the way I think your job is harder in my view is that um, I see some of some of my patients um, get into trouble because of the things people do to each other. I think pretty much all of your casework, caseload is about how people treat each other, whether it's because of bad intentions, whether it's due to mental illness, whether it's due to coping skills, and then there are children involved. I mean, I think if I would have to do that every day, I would find that really, really hard.
Yeah, it is challenging work. You said a few things I want to touch on. I think that is one thing you highlighted that is a difference is I guess in healthcare it's more sort of short bursts. Like you see patients shorter. It's usually pretty quick where I can have a case for a few months. But there's different areas in child welfare, and what I do specifically is I do the initial investigations. So a fair amount of my cases actually, there's no abuse or neglect. It was just someone had concerns and I had to investigate it. So I actually, a lot of times that is the case. And even in times when there is, usually most parents really do love and care for their children. It's super rare exceptions for that. Sometimes people need some guidance or some services or other stuff. But in general, even people who do things that, would make most people pucker and be like, whoa, 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 really do care about their kids. So that's good. That's a positive side of things. And then I feel like there's something else I was gonna touch on, but I'm blanking. Hmm. But yeah, it is. Oh, I was gonna say the other thing is for both of us is that we often see people on one of, if not the worst days of their life. And that's especially true when we have emergency cases where we have to meet response essentially immediately. And that case has to be pretty bad if we do. And then you're having people sometimes come in with emergencies, with serious health conditions. I mean, that I think gets draining just seeing people at just really, really difficult points that aren't, I mean, that's not most of life. Most people's lives aren't spent in the hospital going under anesthesia. Most people's lives aren't spent, with child protective services showing up at their door. And we just see
Yeah,
these moments that can just, I mean, they can just build. And then there's all these other expectations, as I'm sure you have with paperwork. And then I have to go to court and testify. And then, I'm hearing a coworker story that's really horrible. And now that's in my head. And then it's just, it can be a lot. It definitely can be a lot. Um, so I wonder, one, do you feel the same way? And two, what does your peer support group look like if you can talk about it, and how
yeah,
helpful is that?
yeah. I do feel the same way, but and I'm sure you recognize that at the moment itself, you are in action mode. You just do whatever is needed of you, and that
Yeah, it's
also
usually
feels
only
good,
later that you almost
right?
process all of it.
Right. So at the moment, this is what you've been trained for. So this is what you're going to do. Um, so yeah, I think um, our peer support group is one of the most important things of how we deal with it. And our peer support group in our hospital or our department, I should say, is really, really strong. And it's stronger, I think, than in most hospitals. So we have a very active peer support group. I think I'm not sure about the exact percentage, but I think about 10% of our department is trained peer supporter. And those are anesthesiologists, they're anesthesia nurses, post-anesthesia care unit nurses. They're OR nurses. So all of these are represented. Also, the residents have to have their own peer supporters. And if something happens on the OR, which we think has had an impact, uh, anyone in the OR can say, "Hey, let's contact peer support," and they will make a list of all the people that were in the room at the time. So we get an email, okay, something happened on this day, and get a really tiny description of it. A patient died in the OR. And we will get all the names and we will start dividing them. Okay, I will call him, you will call her, and we approach people. So it's not that people have to approach us.
Hmm.
People don't have to find us, because that's a lot of peer support programs. Also, the main peer support program in our hospital, you get a question. If you want peer support, you know where to find us. There's this email address, and then we will, if
And
you
then
if
you
you
have to
want
go
it,
out of your way and basically
you have
say,
to. Yeah, yeah. So you have to think, do I want peer support? No, I think usually people say, no, I think I'm fine.
yeah.
At
Yeah,
the
no,
moment they're
that's a big
fine.
distinction getting reached out to versus having to
Right.
say yourself, "Oh, I need it."
So, right. Oh, I need it. And then you don't know who's coming, right? And whether you know this person, probably not, and whether you trust this person, I mean that's still going to be an issue, anyways. But so what we do is we approach people directly. We try to do it on peer level as well. So if it's a resident, it's usually a resident that will approach them. If it's an anesthesiologist, it's usually an anesthesiologist that will approach him or her, and then we will just say, hey, I heard you were involved in this case. Want to grab a coffee, and then we'll just sit down. And usually they say yes, or sometimes they say no, I'm fine. That's it's not mandatory. Um, but often they say, oh, I think I'm fine, but yeah, let's do a coffee. And then we split it up in 3 sessions. So the first session is just sit and talk. Can you tell me about the case? Um, and we don't ask too much about feelings, but they will express it, and we give
Hmm.
some what we call psychoeducation on what kind of things you can experience after an impactful incident. Sometimes they will say, I've had a sleepless night last night, and we can normalize all that because it's what we call an acute stress response. Um, and so we can talk about normalize the things that they might be experiencing. We can give them some coping skills, and then we say, okay, why don't we meet again in about 2 weeks and see how you're doing. And everything that you experience in between, it's totally fine. If you want to reach out, you know where to find me. And then in 2 weeks, we sit down again. We talk a little bit more about, so how have the last 2 weeks been? What have you been experiencing? Do you have any symptoms? Are they getting worse or getting better? Um, and we have a final meeting in 4 to 6 weeks after the incident. We check how they're doing, if they have had any acute stress symptoms. Have they decreased, or maybe didn't have any problems in the beginning, but they started re-experiencing later on? So that's really our check moment. Okay, is someone going into post-traumatic stress syndrome, or is it just an acute stress response that's fading away, or didn't he maybe he didn't have any problems in the beginning, but he's getting more and more symptoms right now, and that's when we uh, transfer. I don't know if that's the right word. We suggest that they get extra care from social work or psychology. Um, so we refer them. That's what I wanted to say. We refer them for extra mental health care. So it's both a monitoring program as well as just a diffusing um, opportunity. And I think diffusing is already a big part of just dealing with whatever happened to you. And it's what I also think is that a lot of people are um, kind of feel taken care of when someone just approaches you and says like, okay, what we go through, it's not always normal. It's okay if you don't feel okay for a while. And if you need something, if you need some care, if we need to take you off a difficult case tomorrow, we can think along. And I think just making that explicit is already helpful, and it doesn't always have to be this formal. But I think it also sets a good example that it's just very normal for us to go to each other and say, you've had this difficult case, even if I'm not a peer supporter for someone. So how are you doing? If you want to talk, you know where to find me. We can go for a walk, or just
Yeah,
it's
yeah.
it's so normal to know that you can have a stress response after a big case.
Yeah, well, first off, what an amazing program, and the way you guys do it sounds great. And it's so important, I think, for people in our fields because for one, it's like we've talked about, it's stressful work. It can be draining. You can see some rather traumatic things. Two, a lot of this stuff is very confidential, and you can't go home and tell your family. And even if you could, they probably wouldn't want to hear about, the horrific injury or whatever. But a lot of the stuff in there is really confidential, and the only people you can confide in is your colleagues. And
Mm.
then three, it's so important to be able to explain it to someone who understands the work as it's done instead of, we talk about that concept a lot, which I really like. And I think what complicates it is when there's external stuff, right? You guys get in the news for a case, criminal charges. I'd love to talk about Redondavat too. I know that's a that's a close one here, but yeah, it's what an amazing program, and yeah, it's so important. And we do that all the time. I know we have a formal system. I think it's more on the end you're talking about where I would have to go seek it out, and they have some counseling and other stuff, but informally, I the team I work with is great, and if any of us have a really hard case, we're always checking in with each other. I One of my coworkers, she had just an unbelievably awful case. I can't even I can't explain it, but it was really bad, and she was in the hospital for a visit, and I was going to another visit kind of in that area, and I was like, hey, I'm gonna come. I don't even think I would have been allowed in the room. And she kind of told me that. I said, I'm gonna come sit in the parking lot for an hour. I have an hour between my
Mm.
next visit. If you need anything, I'm here. If you need me to come in, if you need to step out. And ended up just sitting in this parking lot for an hour. But she sent the nicest text. She was so, so grateful and happy that I even did that. I mean, I felt so good that she just felt a little more supported working this
Right.
just awful case. Um, but side note, let's should we talk about Redondavat?
Sure.
That's an interesting
Sure.
one. So to give some background, and Rebekka, I think at this point you can explain the case much better. But Redondavat, she was a nurse at Vanderbilt in Nashville, and this story hits pretty close to me. That's about 20 minutes down the road. And it's a really, really good case study when talking about safety science and healthcare. And there's a lot of interesting ideas and stuff to explore in it. And Rebekka, for our entire course where we cover a case study, this is the one she chose and explored it through different lenses. So with that said, I guess we can yeah, just like the assignment. Let's start with the
Yeah, yeah.
case study summary.
So yeah, Radonda Vaught was an ICU nurse at Vanderbilt University Medical Center in Nashville, Tennessee. And it was Christmas, I think 2016, 17, when she was taking care of a patient, or actually a colleague of her was taking care of a patient, Charlene Murphy, 75-year-old to a woman who came into the hospital with a brain hemorrhage. And on the day of the incident, Redonda Vogt was the float nurse. She was the what they call the help all nurses position. So she was available to help out any of her colleagues when they needed it. Um, and the patient, Charlene Murphy, she was improving. And they wanted to do a PET scan to see if there were any underlying causes for her brain hemorrhage. Um, and when she came to the PET scan area, she told the radiology technician that she was claustrophobic. So the radiology technician asked for a sedative for her. So this was called up to the doctors of the unit where Charlene Murphy resided, and then they ordered 1 to 2 milligrams of Versed. And Versed is a sedative. Midazolam is the generic name. Um, and the nurse taking care of her asked Redonda Vogt, can you get this medication and take it to her and administer it to Charlene Murphy? And she did. So she took out the medication out of automated medication dispensing cabinet. Um, when she looked under the name of Charlene Murphy, she couldn't, and she looked up Versed, she couldn't find it. So she didn't. She used an override of the machine, so she could access any medication. She typed in VE for Versed and tapped the first medication that came on, which was actually not Versed, but vecuronium, which is a paralyzing agent. Um, Took it out, ignored a whole couple of warnings where it said paralyzing agent. She just tapped it away. And went down to the radiology department, to the PET scan area, and administered it to Charlene Murphy, thinking it was sedative. Walked away, and I think in 10 or 20 minutes later, when the radiology technician found Charlene Murphy, she was not breathing. They called in the Code Blue team, and she died the next day. So this was a medication mix-up. She took out the wrong medication from the automated medication cabinet. So this is going to be the first story, as we
Yeah,
call it.
so so I was gonna do a quick recap first story, and I think I was discussing this case with my fiance's aunt, who's an attorney, and to her it was super simple even after I explained the second story. But the first story is so Redonda Vaught, she's a nurse, she's in charge of administering this medication. She actively overrides the medication cabinet. There's what is it? There's I don't know if it's the same in Amsterdam, but maybe it is universal for healthcare. Aren't there like 6 steps you need to follow when you get a medication or something like that?
Yeah.
So,
So it's the right person, right medication,
yep.
right dose, right time, right administration route. So there are a number of these
So
things.
she
Yeah.
overrode the medicine cabinet. There was warnings that it's a paralytic. She skipped over those, went down, gave it to the patient. Patient died. On the surface, it sounds terrible, right? Especially if you don't know healthcare. You're like, she overrode the medicine cabinet? I mean, that's insane. Who would override the medicine cabinet? And then we
Yeah.
I'll leave that for you for for second
Yeah.
story.
Yeah. And why did she just not see the 5 warnings that she just
Yeah, it's
uh,
obviously she should have known, right?
yeah, gross negligence, right?
So what's
Well,
the second story here, Rebecca?
well, first, I just want to say also that she was convicted. Um, she was criminally prosecuted, which is very rare for
Yep,
medication error.
by a district
And
attorney in Nashville, Glenn Funk.
yeah, you know that better than me. Um, and this made the case very, very interesting and very horrific as well for many healthcare givers. So the second story is let's see where to start. So there's so many components in this story that I could touch upon,
I think
but
or yeah, sorry, go
yeah,
ahead. I was gonna
Yeah,
say, of
yeah.
course, the overriding and all of that
The
and what that looks
overriding.
like,
Yeah,
but
yeah. So what? Yeah, she used an override. Why did she use an override of the medication cabinets? In the months before, a new system, a new electronic health record system was introduced. Um, and I know this electronic health record system because we use it in our hospital as well. And the transition to it, it's been such a major transition because everything changes. All your hospital processes change. Uh, and it takes, even if you take 2 years of preparation in your hospital with IT departments and all the departments, there are going to be glitches and hiccups,
yep.
and it's going to take another year to figure them all out.
And you're adding
And in the
more
meantime,
complexities to people
absolutely,
trying to manage this new system.
absolutely. And so everything changes. And in the meantime, you still have to take care of your patients. So you're going to use shortcuts, whatever is handed to you in terms of shortcuts or whatever you can figure out how to take care of your patients, you're going to take care of your patients. So that's our number one goal, taking care of our patients. Um, so when this new electronic health record system was introduced, um, there were problems with delays from medication prescriptions from the doctors going through a pharmacy check and then being entered into the system, which communicated to the medication cabinets, which meant that if you were looking for a medication under a certain patient's name, which was just ordered in the minutes to hours before, it might not be there yet
Hmm.
because of the delays. Which could obviously have been the case here. It wasn't the case, but it could have been the case. So if you cannot find a certain medication, to Radon it must have made sense. Okay, this is just one of those issues again, and to get the medication to the patient in time, because the radiology department is pushing, they need to do the PET scan now because their patient schedule after this. Um, let's use an override.
And
To
then,
her, that was not abnormal behavior at that point in time.
and how many times had that same medicine cabinet been overridden in the past, what was it, 48 or 72 hours?
Yeah, I think in 3 days for this patient alone, it was they used the override 20 times.
For this patient
Just for this
alone,
for this for this one patient.
20 times.
So for
What does that
for
tell
the
you?
for
It's normal work.
it's normal work. It's the way you get work done in this hospital. She was not doing something extraordinarily stupid. She was doing what was needed to get the job done.
And
And
ultimately, patients would be harmed and if or not die
absolutely,
if professionals didn't override that medicine cabinet to be able to administer medication in time and make sure that the system's still functioning. So it's you're placing these nurses in a position where they have to override the medicine cabinet.
right, right. And so there's this other problem. So she could have actually found the medication under Charlene Murphy's name, but she didn't because she used the brand name Versed, and not midazolam, which is the generic name.
Mm.
Now in the Netherlands, we have been moving away from using brand names a lot earlier than I think has been going on in the US, because I think in the US, pharmaceutical companies, um, they have a lot of interest in the using brand names, promoting their brands. Um, they're usually easier names to remember. And also there are anti-substitution laws. So if you prescribe a certain medication with a certain brand name, you cannot just use a similar
Mm.
medication from
I mean,
another
some of
brand.
the names get, and I don't see it obviously nearly as much as someone in the healthcare field, but sometimes when I do drug screens or, I'm talking about health conditions or I need to know people's medications, it gets really confusing. Some of the names and people will say it to me. I'm like, I don't even know how to spell that. I'm like,
Right.
like it, and
Yeah,
there's so many different medications, even addressing the same things with all these brand names and otherwise.
absolutely. Absolutely. So yeah. So where we would use midazolam, and know, this is the generic name and whatever brand we get
Hmm.
is the brand we get, but it's going to be midazolam. She was using the name Versed. That's how I talk about it. So yeah, I'm going to give Versed. And then when you go to the machine and you think like I'm going to get Versed, but the machine is programmed to use generic names, midazolam, she was not going to find it because it didn't accept both names. So and then when she overrode it, she typed in VE, tapped the first medication that got on the list. Why she did that, who knows? I don't think she will even know. But there's so many things that can go wrong reading medication
Yeah,
names
and
or reading
perhaps she had,
anything for that instance.
I'm sure she had experiences before where she did that first two letters of whatever medication override. It's the right one, you know. She,
Right.
what what we know for sure, and to be super clear to anyone listening, is she did not intentionally kill this patient. There's no evidence at all that she was like, I'm gonna give her a paralytic. It was an accident. It's super clear on that, and she was still charged
Absolutely, absolutely, and
criminally.
yeah, and then so she took out this medication. And there were a lot of warnings, on the vial itself, but also in the medication cabinet. But she's an ICU nurse, so she might take out vecuronium for other reasons. She might take out paralytic agents to paralyze patients who are on ventilators. So these warnings, who may seem very obvious for someone not working in this field or not working in an ICU, a nurse working on a general ward, they might think like, "Hey, what's this warning for her?" These warnings are something that she sees daily.
Well, they come with a lot of medications, right? So
They come right.
you kind of just
So
click away. You're like, yeah, no, this is
yeah,
the
you're used to clicking them away
yeah.
because they're just, okay, yeah, I know. So you click them away. You don't actively see them. That's just how the human brain works. Um,
Well,
so yeah, and
imagine
then
if you try to spend all your cognitive energy on every task you have to do as a nurse. I mean, you wouldn't be able to do anything.
right.
Like if you're like, hold on, let me read every word of this medication warning and then this medication. I mean, you don't have the time, resources, or energy to do it.
So even sitting here now, I am wondering on our paralytic agents, and I've been wondering that for a while, and I still haven't looked properly enough. What does it say on our vials of our paralytic agents in the Netherlands? Does it have this wording on the cap? It might have, it might not have. I don't even know, and I use this medication daily.
Yeah,
So
yeah,
yeah,
that
that's how
exactly.
that's how that's how wordings work, right? Um, so yeah, and then there's this problem with barcode scanning. Obviously you have to double check your medication, and then a final check at the bedside is you scan the medication and you scan the patient, and then in the electronic health record it should check whether this patient is prescribed this medication. She would usually do that, but when she came to the PET scan area, where she doesn't come very often because ICU patients hardly ever
Yeah,
get to the
she's
PET
just
scan
helping
area,
someone out with this.
she's just helping someone out, but also she's not familiar in this area. And there are no barcode scanners there because it's not usually an area where people get a lot of medication.
Mm.
Uh, so the hospital chose not to have barcode scanners implemented there, or not yet. I don't know for sure, but they weren't there. Um, so there's so many components, and there are even many more than this that were in the system that set her up for failure. And of course, she made an error, and she acknowledges that, and she
She
actually
reported it immediately.
when she found out, she reported it immediately to her supervisors. And what the hospital did is they fired her. They didn't put into the death certificates that this incident happened. Um,
That's another.
and yeah, that's very interesting. So the hospital tried to cover it up at first. They fired her, and they did report it to the nursing authorities, nursing board. I don't really remember what it's called in the US, but so they in the end took away her license, and then she was criminally prosecuted. Well, there are so many system issues, and that's also what she said while awaiting her verdict. Like she says, uh, I own this, but I didn't work in a vacuum. Uh, I worked in a hospital system, and that is what doesn't get acknowledged at all in her criminal trial. Is that there were so many problems, and firing her is not going to make healthcare any safer for anyone.
Nope.
Because this is what, 20 overrides for this just this patient. This could have happened to any one of those nurses, and that's, I think, also why this case made a lot of caused a lot of outrage amongst healthcare givers and especially nurses. Like they were standing with signs like "I am Redonda Vogt," and it really is true. It could have happened to any one of those people. It could happen to me tomorrow.
That's what, oh, this case gets me fired up for exactly the reason you're saying is there's no evidence that she wanted to harm this patient. Quite the opposite. She's super motivated as a professional, as someone who dedicates their lives to helping people as a nurse, to not harm, let alone kill a patient. And then
Right,
charging her criminally just it's so grossly disconnected from the actual work that's done. And it is amazing how many nurses came together and they were so, like you said, saying, this could have been me. This is unbelievable that we're prosecuting her. And I know criminal stuff is so different from what we talk about in our master's program, but it creates a lot of problems. And if I remember right, she actually got convicted but got no time. The judge was
right,
like, you've been punished enough. So we have that whole aspect where she's a second victim. We like using that term. Basically
yeah,
saying she also experienced this. She engaged in a behavior that led to a patient dying. She feels terrible, independent of any you know, punitive actions from Vanderbilt or from the criminal side of things. It's just unbelievable to go after her. And then it creates so many more problems. Like, if your goal is to learn and improve this system, what's
yeah,
really important is we have this nurse who's super motivated not to harm her patients. This event happened. Let's understand why it happened. And it's everything you said. But when you look at the criminal charges, it's much simpler. She ignored warning signs. She overrid the medicine cabinet. She killed this patient. And then you
right,
learn nothing if you hear that story about what can be done to better support these workers who work in a super messy, complex field where oftentimes there's already, or pretty much every time, there's already harm that's already been done before you guys even see the person. And I
right.
love that nurses were so angered and outraged by her being criminally charged. And then it also just makes people less likely to disclose information because I make a mistake. I don't want to be punished. I don't want to be fired. I don't want to be criminally charged. I'm just going to start hiding stuff.
Right, exactly, and that's Rodona Vaught did all the right things. She we are discussing accountability for our next assignment. Um, she was giving account. She reported it immediately, and she was all open for helping the investigation. Like, how can we improve our system? And she was punished for it.
Severely.
Accountability turned into let's blame her, and then the problem is solved, and we learn nothing from that
And it's
except to hide it, except to hide our any mistakes and errors.
like who really just felt better about, I mean, I'm sure people did, and obviously I think we think differently than a lot of the media and legal side of things would portray. But who, like, what makes society better charging her with manslaughter? Like, in what way is it just because someone died, so someone has to pay? Like, that's the only thing I can think of. I mean, if you understand, and I'm not a healthcare professional, and I still, the way you tell it is really compelling, and you understand all this different stuff going on that existed in her world and why decisions made sense to her in real time, and you still just want to punish her just for what?
Yeah, so I wonder it too, but if your system is built like that, so if you are working in the judicial system, um, what's your local rationality? Uh, so people do what makes sense to them. So what's the local rationality of a judge or a lawyer? Um, and it might be different things, but it might just be making money out of a case. But
Yeah, they're
it might
motivated
be,
to win cases.
but
I do think though, going to local rationality, these district attorneys, they do, they do the work wanting to do a good job and wanting to protect the public and interest. It just gets really, really dicey when you have cases like this where you're right. It feels so different if
yeah,
someone say murdered someone.
yeah,
It's
of
like
course.
everyone can get behind. You can get consensus on, yeah, that's really bad. This is more. It's just a oh, I can't even articulate it well. It doesn't feel good. It just
No,
feels
it
like so
doesn't.
icky going after a nurse and I think a large part, like you were saying, is that other nurses were like, this could have been me. You guys are
Yeah,
placing us in
yeah.
this position. But yeah, I do
I,
wonder why
I
they chose. It would be interesting to understand why Davidson
it,
County
yeah,
chose to
absolutely. And
prosecute this case.
I think also it might be that they really do believe that this is going to make healthcare better. Um, in our professional disciplinary courts, they also, they reprimand individual caregivers for issues that are often deeply ingrained into system problems,
Hmm.
um, thinking that they make healthcare safer. Uh, So what's their local rationality? It makes sense to them, and I think the way we, the way the things we learn in our program, and I think the things that you grew up with the collaborative safety mindset, is quite progressive. But if you just grow up thinking about right or wrong, and is it so weird that they think, if we just punish the people that do wrong, it will have a deterrent effect for someone else to make the same mistake. Um,
And we
you
we
have
would
to
argue
really,
differently, but yeah, it
we
makes
would
sense
argue
why people think that.
differently. But you really do have to get a grasp of what complexity is and how it works and how it doesn't work to understand what the role of the system is and
Yep.
how this isn't helpful. But if you haven't learned all that, um, intuitively, I can see how it makes sense that deterring someone by punishing wrongdoers feels logical.
Yeah, and that's a really good way to put it, absolutely. And then also a lot of stuff that exists is external pressures. So say,
Right.
the news is talking about this case, the family's outraged, they're speaking out about this case, and stuff like that does also exist as it exists in any job and can, shape decisions that are made and influence things. But yeah, no, you're right, and it is easy or I don't know easy if easy is the right word, but it is important to understand why things made sense to everybody involved when we talk about these cases. And then I mean, when we go into the legal thing, it starts getting a little more moral and philosophical, and what what is right and wrong, and all that gets really interesting because
Yeah,
we
but
like to.
yeah, yeah, we have to meet people where they're at, right? So we do have to understand if we want to change anything in the system, we have to look at the local rationality of the people involved in that part of the system as well.
Yep. And in
That's
Decker's
how I
book,
see it.
Just Culture, he talks about this, and we like to think that court is the most objective place, but it's of course not because I mean, for one, you'll have drastically different outcomes depending where your case is held, whether it's city, state, country. And then also there people have expensive attorneys who win a lot of cases for a reason. And it's a lot of it's arguing one's interpretation of the law. I mean, it even gets
Mhm.
confusing as a worker with you can interpret policies differently. I mean, Oh, it's I could go down a rabbit hole, but I won't. But yeah, it's no, what an interesting case. I love the way you talked about it and the way you explored it was really cool. And I think it's an excellent case study. I hate that that happened to Redonda Vaught. I mean, I don't know what she's doing now, but we'll get her on the podcast one day. No,
Hopefully.
I don't know if she'd feel comfortable talking about it, but it really is a powerful story.
Yeah.
And yeah, I'm glad that that nurses and other people do appreciate the gravity of this situation and what happened. But let's well, what I know I asked you to be on here. Did you have anything that you wanted to talk about? Were there any specific topics you wanted to discuss?
Um, Not specifically. So I knew you have some questions prepared. I don't know if you've been through them already.
No, I don't really prep too much. I kind of just go with the flow on these conversations. But yeah, what I guess we can switch more to Loon because you were involved in the program. I mean, I knew about it for a while through collaborative safety, but you actually went to a learning lab before our
Yeah.
first one, right? So what inspired that? I know we talked a little bit about this, but let's go back. What brought us to Loon and then we'll go from there.
Yeah, so what brought me to Lund is I think I'd been thinking about going to this master's program for a while. I think about 2019 was when I started
Quick
thinking about this.
quick side question because I get asked this and I don't know if I'm always explaining it best. People be like, "Well, so what's your master's program?" I'm like, "Oh, human factors and system safety." And then often I
Right.
just get a blank stare like, "Okay." So how do you if someone asks you that question and they say like, "What does that mean?" What do you say?
Yeah. So my short answer is I'm learning about how safety works in complex systems.
I'm stealing
That's
that.
that's that, that- that's my really short answer because it's just not that easy. It's we don't have a linear cause and effect in complex systems, and
Yep.
complex systems are for me systems where there are so many interactions between people and other components that no one has a complete overview of what's happening. No one can have a complete overview of what's happening all the time. So no one really understands the state of the system at any point in time. So what we can see is small parts of the system. From my viewpoint, you can see a small part of the system from your viewpoint. And that's all the information we have to make our decisions and do our actions. And we are pretty good at that. So usually things go right. But with the same intention, sometimes things go wrong. So how do we create safety in such a system?
That's a really good way to say it. Better. It is funny, I think sometimes, someone asks me that question, I pull like an Axie map out of my back pocket and they're just even more confused. They're like, what's going on here? But yeah, that's a really good way to put it. And then obviously you can tailor it, depending who's asking. If it's a
Oh yeah.
colleague, you can say, well, here's how this applies in healthcare a little bit.
Oh yeah,
Um,
yeah. So in healthcare, I would say, okay, let's say in I work in a university hospital. Let's say the power goes out, um, and it doesn't. In 10 minutes later, it's still out. So a lot of processes will start to happen. We will cancel ORs, but on the outpatient units, physicians or the secretaries at their desks, they will start canceling patients, and they will probably make something up like, I will call you later today or
mhm.
tomorrow to give you a new appointment. And they will start doing all these things, even though we might not know exactly, it's not exactly planned out, but things will start to happen. Some of it might be pre-thought of, but not all of it. And do you think that anyone in the hospital knows what the state of the system is at that point, what's going on, and whether these are rational decisions or not? I mean, these are locally rational decisions, and they're probably really good decisions as well. But people start to take care of it at local levels everywhere in the hospital. They start
Yep.
doing things that make sense to just, keep taking care of patients in the best way they can. Um, and even the CEO of the hospital won't know exactly what's going on.
They actually might be more disconnected than
Totally.
than a lot of
Totally,
people, but
and they hopefully they have some large overview, which is
yep.
great. Someone needs to have that, but they don't know on a detail level what's going on in the hospital, and that's fine. Um, but we keep talking to each other, and we try to make locally rational decisions, and most of them will be good, and some of them might not have the best outcome, but most of them will.
And you're placed in positions where you have to make almost impossible choices and just do what makes sense in real time and adapt to all the complexity and
Yeah,
usually it works out like you're saying,
yeah.
which it becomes
With
problematic when we start punishing people for, you know, normal work.
Yeah, yeah, you're constantly working with incomplete information, and not enough time and resources to find out
Yep.
everything that you might need to make a better decision.
Yep.
Yeah.
Well, all right, back to what you got you into loons specifically.
Yeah, so 2019, I think I was thinking about, I just finished my anesthesia and intensive care training, thinking about going to Lund because I was already involved in patient safety subjects. Um, and it was actually my brother who told me about the program, because he works in aviation. He's an airline pilot, and he had
Oh,
some colleagues.
interesting. I didn't
He had
know
some
that.
colleagues working, or who did this master's program.
So for some
Um,
more quick background in our master's program, it's a lot of aviation, oil and mining, railroads. So our fields are a little bit different, but it is pretty amazing how these concepts all align. But historically, I would say aviation has been the dominant discussion in safety science literature
True,
and
true, yeah,
nuclear stuff like that. Um,
right,
but yeah,
yeah.
that's really cool. So okay.
Yeah, so I think that's also where we find each other, because he doesn't know too much about medicine. I don't know too much about aviation. So where we find each other is talking about safety. So that's why I said, this is the program for you. You should check it out. Of course, then COVID happened, so
Oh
didn't
yeah,
think about it for a while.
2019.
2019, 2020. I was working in intensive care unit, so
Oh no.
yeah,
Oh,
things happen.
we're gonna need another podcast to talk about that experience, I'm sure.
Yeah, I'm sure too. Um, so yeah, then I went to work on Bonaire, on the Dutch Caribbean islands. Well, I had a case. You've heard about it. I cannot talk about the details here, but it was a really bad case. I ended up with PTSD myself. So that was in 2021, 2022. I spent at home on sick leave, just to deal with all my mental health issues at that time. Um, and then I had to, after that 1.5 years of just getting back into my job full time. So it was 2024 when I was, kind of back on my feet.
Oh, I'm so sorry
Tr
that that whole experience happened. And how amazing of a support are you for people going through a similar situation because you've experienced all that? I mean, it, it's awful. You wouldn't trade that, of course, but wow, it's really good that you're a part of that peer support program. And I mean, it's so genuine. You could relate to, I imagine. I mean, I'm sure there's some exceptions, but just about anything anyone could experience in healthcare, just the range of stuff you've done. So that's
Yeah,
really powerful. And your
thank you.
ability to tell these stories and be vulnerable and talk about it too is also really powerful. So I know we all left when you shared some stuff at the last learning lab, and I was just like, wow. I mean, I still think about that story. So thank you for sharing that one. But 2024.
Yeah. Yeah, 2024. I think even a little bit before that, 2023, I went to a patient safety and quality masterclass of the European Anesthesia Association. And there were two course directors there that did the program in Lund, Christopher Neuhaus and Michael St. Pierre. Um, and they taught me stuff that I didn't really know about before, especially thinking about first story, second story, local rationality. So local rationality is it's means that it always makes sense what someone did given the things they thought about the state of the system, the experience they have, the knowledge they have, the time frame they have. People don't do things that don't make sense.
We
So
don't operate in a vacuum.
we don't
Every
operate in a vacuum.
decision makes sense to us. Otherwise, we wouldn't
We
make
wouldn't have
that
done it.
decision.
And so this
Which it
this
sounds so
changed.
simple, but it's so hard to actually grasp when we talk about these complex cases and stuff, right? Because on the surface, you're like, yeah, of course. But
Yeah,
then it's
for me this was transformational because I spent a year at home thinking about what I did wrong. I got a lot of feedback also that, I did something horribly wrong. And this became my story in my head. I did something wrong. I caused patient harm. Um, and now there were these people talking about these concepts like, okay, you did, you must have done what made sense at the time. Otherwise, you wouldn't have done it. So this led me to revisit my story, thinking about, okay, why did it make sense at the time for me to do this? And it made me look at myself differently. Okay, an outcome may be good or bad, but you did something with the right intentions and you did something that made sense at the time. Um,
and even then,
so
you still feel bad about it, even
of
knowing that,
course,
which speaks more
yeah,
to the volume of how, when we punish and prosecute practitioners for engaging in normal work, I mean, we punish ourselves.
right, we do. We do. Yeah, but this had been really, really helpful, and that's when I thought, okay, where did they learn all this stuff? They learned this in Lund at this master's program. I'm going to check it out. So I went to the second learning lab, which is on the ethics of safety. Um, and there were so many interesting topics, but I learned more about this first story, second story from Roel van Winsum on stories from the Dutch Railway,
Which is
and about
another on the surface seems like a simple concept, but it's you could go so deep into it. But it's so good. Local rationality, first, second story, work is done versus work as imagined. Those three concepts I really, really like and think they apply so well to our fields. I'm sure every field, but I know for us we can relate really strongly.
sure, yeah, definitely. So yeah, and that's when we got this assignment. Okay, go sit in groups and bring us a story, a first story and second story, and so I went to them and I said, like, okay, yeah, I would like to share my story, but the assignment is bring your first story in 2 minutes and your second story in 5 minutes. And I cannot bring my second story in 5 minutes. I need a little bit more time.
Not even close. You
So,
you're not even like 1/50th of the way through your story.
right, right. And so they actually made some time for me. I told them I needed half an hour. I took about an hour. And by the end of the hour, everyone was silent or crying, or it just made a huge impact on people, and it made an impact on me as well. Um, and yeah, so that's the response that I got was so impactful for me,
Yeah, yeah.
but also impactful for people just sitting there listening to this story.
Which makes it more
Um,
impactful for you that it is impactful to other
Absolutely,
people. And you're in a
absolutely.
space where people can really appreciate and understand, not of course on the level you do, but actually say yes, like I'm so sorry that happened. I see why everything made sense. I've done something similar in my field. I mean, I used the word powerful earlier, but I can't think of a better word than your story really is powerful.
Thank you. Yeah. So yeah, I think it resonates with people who've been through similar processes, but I also think it resonates for people who are involved in incidents, for instance, incident analysis in their own company. So I retold the story this year. That's when you heard it as well. I took more than 1 hour. I think I took 1 hour 45 minutes this time to tell my whole story.
You got a
Um,
half a day.
um, but I had people coming up to me and saying, "Okay, I really thought I was getting the second story from people, but I don't think I ever talked to anyone more than 15 minutes. So I don't think I ever got a real second story out of anyone if I hear your story and how much detail there is in the context,
Yeah.
why it made sense, why everything made sense. So
And it's
yeah, I think
difficult to
it's
do.
it's very helpful.
I'm sure it was a entire process for you. I mean, one, thinking about this event that is you feel terrible about, and then reflecting on everything and looking back and having to access all this information and then interpret why it made sense. I mean, that's challenging to do. And I think a goal of people who do these incident investigations should be to help people be able to tell that story and asking, the right questions, open-ended questions, making sure they feel safe and comfortable is a huge step in that direction.
Right. It is a huge step, and I think people themselves tend to blame themselves as well. And I created a first story in my head as well, which was really simple. I did something horribly wrong, and I shouldn't have done it. And now I have harmed the patient. Um, so to be able to help
And then, like
construct
you just
this,
said, in reality, there was an hour 45, and you probably kept some details out that you could talk about
sure,
just on why things made sense to you instead of I
yeah,
harmed a patient. First story.
right. Right. So yeah, I think Roel has heard the story about 5 times right now, and he says like every time you bring something new. So that's I guess my goal to surprise him every time I
Yeah,
retell the
yeah.
story.
Oh, I
Um,
hope they have you coming back to tell that story for a long time, even after we graduate, because I mean, that is, and I think another thing we haven't touched, like we've touched on, but haven't talked about is the importance of storytelling and narratives and other stuff. I mean, it's so central to humans to create stories. And I mean, the work I do as I'm gathering information and then relaying a story. And it's
right,
so important in the story we tell ourselves and the story we tell other people and the stories we use. I mean, it's just, and you can craft vastly different stories as we were talking about earlier. A prosecutor, the narrative makes sense to them and they can craft a narrative. Likewise, we can craft a narrative making our argument for not prosecuting Redondavat. So storytelling is so important and powerful. And hearing a story like yours is just it's so much more memorable than you pointing to a PowerPoint and being like, here's a concept.
right.
Like I will
Yeah,
not remember that, but I will remember the story that you shared.
yeah, and I think also the power of storytelling is that multiple perspectives can be true at
Yep.
the same time. And I think that's also this really fits in with the local rationality principle that there you might never find out what happened, but you have all these different perspectives of how people experienced it and what it looked like from their part of the system they
Yeah.
were operating in. And so it did make sense for them at the time, even though they might have operated on what in hindsight might be the wrong information because it didn't convey the state of the system as they thought it did, but it was what they could see.
100%.
So yeah, I think that multiple truths um, can be true together, and form the story together instead of just having the goal to find one truth, and so other stories are definitely wrong.
Yep.
I think that's
Different
very
perspectives.
important. Yeah,
Well, Rebekka, this time has flown by. I have a meeting I have to get on in
I
three
know.
minutes, but oh, I'm so sad. I feel like I have so much more to talk about.
Oh, we have time. Some other time.
Yeah, no, we can always, I mean, this podcast, I'm just doing it for fun. I'm super happy to have recurring guests. We can, of course, do another, but oh, I've loved the conversation. I'm so sad I have to have a whole work day now. But thank you so much for coming on,
Well,
for sharing.
thank you for having me, and it's been a blast.
Yeah, yeah, of course. And it's so cool to talk to people who have interesting experiences, and the perspective that you have is just it's I keep using the word powerful, but we're going to use it again. It's really powerful. And it's yeah, I look forward to the rest of the course. Thank you so much for coming on. I'd love to do it again in the future. So yeah, we'll,
Well,
we'll
thanks for having me, Joe, and have a good work day.
yeah, thank you.
And
You have a good
we'll see each other soon.
yeah, is this the start? This is the first week of your 2 weeks off?
No, it's the start of the second week. So
Start
yeah,
of the second week. Okay. Well,
one more week.
yeah, well, enjoy your time off. All right, I'm gonna turn off the record now. Thanks, Rebekka.